Welcome, everyone, to this week's Department of Medicine Grand Rounds. And this week's Grand Rounds will be presented by the three recipients of the Chair of Medicine Scholars Awards for 2021. And the Chair of Medicine Scholars Awards were initiated in 2013, and they are awarded to meritorious University of Washington Department of Medicine instructors or acting assistant professor to foster their transition to the roles of physician scientist and principal investigator. And each award provides $50,000 per year for 2 years, and primarily for salary support, but can also be used to support other aspects of the recipient's research program. And it's really to help them in that transition to a junior faculty position and on their road to independence. This year, we have three recipients. The recipients are McKenna Eastment from the Division of Allergy Infectious Diseases, Leah Marcotte from the Division of General Internal Medicine, and Anna Weil from the Division of Allergy Infectious Diseases. And each individual will be given a presentation for approximately 15 minutes and then can take 1 or 2 questions after their talk before we move on to the next speaker. And to ask questions, please use the chat function. Dr. Tess King will be monitoring the chat function and can pose questions to the speakers, 1 or 2 questions after their talks. So I'm going to turn the podium over to our first speaker, Dr. McKenna Eastment from the Division of Allergy Infectious Diseases. McKenna?
Thank you, Conrad. It looks like it's not letting me share the screen because somebody else is sharing the screen. Oh, there we go. Thank you. Wonderful. Thank you for that lovely introduction. Hi, everyone. I'm McKenna Eastment, and I'll be talking about my work that I've been doing. So a little bit of background. I grew up a significant portion of my life outside the US in Trinidad and Tobago during elementary school and 6 years in Cairo, Egypt, where I graduated high school. I then went to the University of Notre Dame with a pre-med in anthropology major and a gender studies minor for my bachelor's, then went to the University of Chicago Pritzker School of Medicine for med school, and then came here for residency. I remember on my interview day, Ken Steinberg said that he wanted the UW medicine residents to change the world. And I was like, I want to do that. So I came out here, stayed for infectious diseases fellowship, and also got my master's in public health and epidemiology here from the School of Public Health. And then I lived and worked in Kenya from 2016 to 2017, getting my research kind of career off the ground. I'm interested in kind of HIV, women's health, and general ID for my clinical interests. I now provide 25% clinical care at the VA on the inpatient consult service, ID consult service, as well as precepting an ID clinic. My research interests are around kind of global women's health, cervical cancer, and implementation science. I have a great team of mentors. Scott McClelland is my primary mentor in medicine and ID and global health. He was my attending when I was a general medicine resident at Harborview during second year. So I've known him for a number of years. Ruanne Barnabas helps with kind of costing, health economics, and so her background in cervical cancer. Kenny Schur in implementation science and global health. Barb Richardson in biostatistics. Kishore Mandelia in kind of global health and cervical cancer work as well. And then Anna Wald is my career mentor. The project I'm going to be talking about is based on cervical cancer screening, kind of implementation in Kenya. And so many of you know that most of the cervical cancer deaths worldwide occur in low and middle income countries. The cervical cancer is the most common cancer in sub-Saharan Africa. And it is more common and more severe in women with HIV, even if they are on antiretroviral therapy. There's a number of different screening methods: visual inspection with acetic acid or VIA, VLEAD with Lugol's iodine, Pap smear that many of us are familiar with, as well as HPV testing. In Mombasa County, which is on the coast of Kenya, there is a kind of a siloed healthcare, and there's not the traditional kind of primary care model. So family planning clinics were tasked with cervical cancer screening. Columns were added to the register, to the family planning register, so FP register in 2008 to kind of capture the method used and the result of cervical cancer screening. In 2014, a survey suggested that 5% of women on the coast of Kenya had ever been screened for cervical cancer. So definitely a lot of room for improvement. In 2017, we conducted a review of 60 family planning clinics. And 4 clinics didn't record any cervical cancer screening in the FP register. And of the remaining 56 clinics, 7 recorded any cervical cancer screening. And there were 120 clients out of 12,000 clinic visits that were screened for cervical cancer, so about 1%. So again, we have room for growth. This is the family planning register. These are large paper books that you write in all of the visits. The top picture is the left-hand side of the page, and the bottom picture is the right-hand side of the page. And you can see here that it captures cervical cancer screening for the method and then the results. So I applied for and was awarded a KO8 through the National Cancer Institute, a career development award focusing on cervical cancer screening implementation. This is a randomized controlled trial testing and implementation science tool to increase cervical cancer screening. This implementation science tool that we are testing is called SIA, or the Systems Analysis and Improvement Approach. And this is 5 steps. The first step is using a kind of cervical cancer screening cascade analysis tool that I create. And it really helps use actual numbers from the family planning register to understand where there are drop-offs in care. And then there's an optimization function where you can see if you focused on this step of the cascade and optimize this step, how many additional women would be screened for cervical cancer, or how many additional cervical cancer diagnoses could you make and get them into care. So that's the first step. The second step is to use sequential process flow mapping to map out the system. And in this case, it's often the family planning clinic, from when a client enters the clinic to registration, seeing a provider, going to the lab, going to the pharmacy, and then checking out, to really understand the flow of the clinic and where there might be areas to improve efficiency or to improve care. Step 3 is that you identify, you define, and you implement a workflow modification. So this is kind of that continuous quality improvement, CQI, or you're seeing kind of the plan, do, study, act cycles here. After you have implemented this workflow modification, or a micro intervention, as we call them, you assess whether this workflow modification made any difference. You go back to the cascade analysis tool and seeing if you should adapt, adopt, or abandon that micro intervention. And then step 5 is you continue to repeat these cycles, usually every 4 to 6 weeks, for kind of continued improvement. So the aim 1 of this study was to first describe the cervical cancer screening care cascade from identification of women or female clients aged 21 to 65 through referral for follow-up in family planning clinics, and then trying to conduct an analysis of correlates of failure to screen for cervical cancer over a 1-year period. The data that you're seeing now is preliminary, but it's based off of 70 clinics that we surveyed, family planning clinics across Mombasa County. And this is looking at the all clinics kind of characteristics, any that verbally reported to us that they did do screening, and then any screening that we actually found documented in the register. And as you can see, it was about a 50-50 spread between urban and non-urban. Only 38 clinics said that they did any screening, but only 27 had any cervical cancer screening captured in the family planning register over a 15-month period. About half the clinics were private, where about a third were public or other. Many of those are kind of faith-based clinics. The top 3 challenges that providers told us were for cervical cancer screening was lack of supplies, lack of training, and then clients refusing cervical cancer screening. And about half of clients have to pay for screening, which could be a barrier. We also assessed whether there was visual privacy and auditory privacy to actually have conversations about cervical cancer screening and then actually to perform the screening. Most clinics did have complete privacy. And then we also looked at commodities for cervical cancer screening, and speculums were frequently out of stock, but about 2/3 of clinics were never out of speculums. And then looking at correlates of any cervical cancer screening versus no cervical cancer screening, you can see here that those clinics that were larger, that had more clinicians, were more likely to screen for cervical cancer. Public facilities were less likely to screen than non-public facilities. Though it makes sense, but those clinics that had at least one provider trained to perform cervical cancer screening was much more likely to actually perform screening. And that those clinics that were never out of speculums were also much more likely to perform cervical cancer screening. We also looked at kind of management meetings to see if that was kind of a marker of organizational kind of climate, managerial support, but that was not associated with screening. Neither was kind of urbanity. The plan originally was to actually look at individual level data, but this was determined to be quite problematic. Across the different facilities, there were no consistent client IDs, and for privacy reasons, we obscured the name and phone numbers of all of the individual clients. And so there was no way to kind of follow the women over time in the clinics to see, if they were seen in a 3-month period, did they have any screening in the subsequent 12 months? And we only captured registry pages when any screening occurred. So we don't really have that accurate denominator to be able to tell kind of what percentage of all family planning clinic attendees were screened. The second aim of the study was to test whether SIA increases cervical cancer screening compared to usual procedures in a cluster randomized trial in 20 FP clinics in Mombasa County. We launched the study in January of 2020, around the time of the SARS-CoV-2 pandemic, as well as there were healthcare worker strikes in Kenya. The plan was initially for a 12-month trial with 10 clinics randomized to intervention intent to control, but we extended the RCT by an additional 6 months, and this was completed over the summer. And so these data are being finalized, and we're going to begin analyses soon and trying to look at the prevalence rate ratios of cervical cancer screening in intervention versus control clinics. We're also conducting in-depth interviews to understand the acceptability, appropriateness, and feasibility of SIA, as well as an evaluation of SIA using the Consolidated Framework for Implementation Research, or CFIR, as part of AIM 2. And aim 3 is to determine the cost and budget impact of using SIA to increase cervical cancer screening and family planning clinics. This data collection is nearing completion and will be analyzed. I think ultimately we'll be able to examine costs, but probably not budget impact, but that's still to be determined. So implications of the research. So the final results are pending, but I suspect that there's still a large need for improving cervical cancer screening implementation. SIA offers the solutions that kind of work within an existing healthcare system to kind of improve processes and efficiencies. And it isn't that our research team isn't going in and conducting screening, but rather the family planning clinic staff and our research staff are really trying to problem solve and test interventions that might work in their particular setting. And this has implications for sustainability because as the study finishes, the hope is that the staff who have been trained in SIA can continue on in those kind of continuous quality improvement practices. Kind of future directions and career goals. The plan is to scale up this KO8 to more FP clinics if the preliminary data is encouraging. I've also submitted an R01 that's scaling up Scott McClellan's K24 that I led implementation of that helped get me involved in family planning as well as SIA, where we're trying to test SIA to improve integration of HIV prevention and treatment services in FP clinics when delivered by Ministry of Health kind of scale in Mombasa. I also have submitted an R34 trying to evaluate the efficacy and early implementation outcomes of a risk score in enhanced adherence counseling to improve PrEP initiation adherence and continuation in women who engage in sex work in Kenya. And then I have 2 more grants planned, an R34 domestically, testing SIA to improve treatment and prevention care cascades for opioid use disorder and HIV in primary care with Judith Suey in the Department of Medicine. And then a UO1 submission plan for December, trying to improve cancer control and HIV populations in low and middle income countries. And that's with collaborators in the Department of Medicine and OBGYN as well. So in conclusion, I'd like to thank particularly the Chair of Medicine Scholar Award Selection Committees, the NIH for their support, all of my mentors who have been amazing, my collaborators at the University of Nairobi, Kenyatta National Hospital, and Mombasa County Department of Health, our research staff at the Women's Health Project, and all of the clinic staff and managers at the family planning clinics that I have worked with. And I would be happy to take some questions. These are my 2 kids. Isaac is 3.5 and Isabel is almost 8. And this all would not be possible without their support as well as of my husband. So thank you and happy to take questions.
Thank you, McKenna. So any questions that you would have for Dr. Eastment, please put them in the chat, and Dr. Tess King will be monitoring and can ask the question, but I'll just lead off with one. McKenna, how many, what the proportion of clinics that could actually offer HPV testing, what was it in your cohort or your cohort of clinics?
Right. So it's a great question. And so we didn't specify what type of cervical cancer screening method could be used. Most of the clinics are doing visual inspection with acetic acid, kind of being low cost. HPV testing, I think, is kind of coming around. Cepheid and the Gene Expert is working on kind of more rapid HPV turnarounds. Pap smears are used a lot less. They're not liquid-based pap smears. They're conventional, and that requires cytopathologist, and so tends to be much less common. So the vast majority of screenings are probably visual inspection.
Mm-hmm. And how would you instruct the clinics to act on a positive HPV test? I mean, what would they do if they got a positive HPV test?
It's a good question. So next steps by guidelines would, I'm going to be working on testing HPV. If they had a positive screen by VIA, then they would generally be referred for colposcopy and then cryotherapy or LEAP or potentially thermal ablation. None of the clinics, I'm trying to think, I don't think there's practices or processes that are really in place yet for the HPV, but it would probably be repeat testing in 6 months or a year, depending on if they have HIV or not. And then cryotherapy, LEAP, thermal ablation, which those services are available, but just kind of depends on where the clinic is located.
Yeah. Well, thanks. It sounds like your dog has something to say about it.
Yeah, they're downstairs. My cat is sitting behind me,
okay.
Like as I'm presenting. She's right behind me. So.
All right. Well, thank you very much. Nice presentation, Dr. Eastman. And now,
thank you very much.
Now we'll go, and congratulations on the award too.
Thank you very much.
And now we're going to turn to our next speaker, who is Dr. Leah Marcotte. And Dr. Marcotte is in the Division of General Internal Medicine. And so, once again, if you have questions that come up during the course of Dr. Marcotte's presentation, please put them in the chat, and Dr. King can ask those questions at the end of her presentation. Go ahead, Leah.
Thank you. Thank you so much. Thanks for everyone for coming today. Special thanks to Dr. Lyles, Dr. Young, and the committee for the award and the opportunity to share my work. I'm going to be presenting today on applying learning health system models to address cancer screening disparities. I have a couple acknowledgements in talking about this topic. One, just my own positionality as a white woman talking about racial disparities in cancer screening. And I'm always looking for opportunities to improve. So please give any feedback you have on this presentation. And secondly, I just want to acknowledge and appreciate that not all individuals who are eligible for and benefit from breast cancer screening identify as women. There is prior research and our current research in which participants did specifically identify as Black women. And so I will use that identity in this presentation. And to begin with some background, I went to college and medical school at the University of Pennsylvania. Towards the end of medical school, I worked for the Department of Health and Human Services, where I really became interested in health, in primary care delivery reform and innovation. I came to internal medicine residency here in the primary care track at University of Washington. And after residency, I joined an innovative primary care startup called Iora Health. Iora has an emphasis in population health management and operates under a value-based payment model. In 2018, I returned to the University of Washington as Associate Medical Director for Population Health. And it was really in this role that I was first exposed to and involved in learning health system models. And by that, I mean partnerships between researchers and health system leaders to assess health system data or to design research or design health system interventions and evaluate health system interventions using research methods. And I was really compelled by these models because it combined my interest in continuous quality improvement and innovation, and gave me kind of strategies and mechanisms to be able to, for instance, assess the impact of an individual intervention. And so I actually left my Associate Medical Director for Population Health role. I realized I need to update my division profile. And I joined in September of 2020, the Learning Health Systems Research K-12 program. And my clinical interests are in primary care. I'm attending at the General Internal Medicine Center at Roosevelt. My research interests are, again, in learning health system research and primary care, with a focus that I'll talk about today in addressing cancer screening disparities. I've benefited from a really excellent mentorship team, 3 of whom are in the Division of General Internal Medicine: Josh Lau, Kari Nelson, and Ashok Reddy, and Diana Bust, who's a cancer epidemiologist at Kaiser Permanente Research Institute, Washington, and is also a K-12 program director. And I'm going to spend the remaining part of this talk focusing on our work in addressing racial disparities in breast cancer screening, especially among Black communities. I want to point everyone toward the excellent presentation in Grand Rounds by Dr. Rachel Young. That was just a few weeks ago, that goes much more in depth than I'll be able to today, and highlights many ongoing health system efforts to address disparities. But to start with some background, as probably most are aware, disparities in breast cancer outcomes have persisted for decades. In one retrospective analysis of over 500,000 individuals, it was found that people who were Black were more likely to be diagnosed at later stage of breast cancer and more likely to die of breast cancer than people who are white. And here's the survival curve from that analysis for breast cancer death, with the survival curve for Black individuals in blue and white individuals in red. And so it stands to reason that addressing breast cancer screening rates specifically may help to facilitate early detection and improve breast cancer survival. And yet research has shown that Black women in particular experience multiple barriers to breast cancer screening that are really rooted in systemic racism. Some pretty obviously so, like prior negative experiences in healthcare and mistrust of the healthcare system, but some that may be less obviously so, such as fear of diagnosis. And when we explore what fear of diagnosis may mean to a Black woman, we find that, that would mean that that person would need to then interface with the healthcare system that she may not trust and she may have had prior negative experiences with. And so I wanted to set this stage by just explaining that that disparities in breast cancer screening are very complex. They're multifactorial, and they're really entrenched in systemic racism. And so it may not be that surprising that typical population health management strategies like phone calls and letters may not be as effective or may not be sufficient in addressing these disparities. And we see breast cancer screening disparities within UW medicine. And I want to kind of contextualize that with, we are in Seattle, which is a very progressive city and cares a lot about equity. We are in a healthcare system with a chief health equity officer, and that has a priority to reduce breast cancer screening disparities on the health system level. And yet these disparities really persist and are pretty marked. These are data from August 2020, which I'm showing because this is when we started our work in addressing breast cancer screening disparities. And you'll see that breast cancer screening rates among Black individuals was about 61.5% and white individuals was 73.3%. And these numbers have changed a little bit, but the gap is about the same currently. These differences may be even more meaningful when we think about what the number needed to screen with annual mammography to prevent one breast cancer death is only 84 individuals. And so we gathered a team together of health system leaders from primary care and population health, Vicki Fong, from the Office of Healthcare Equity, Dr. Paula Houston, and from the Department of, and some researchers from the Department of Human-Centered Design and Engineering, as well as a leader of a community-based organization, Bridget Hempstead. To really focus on this question of how can UW primary care and population health improve outreach efforts to address breast cancer screening disparities among Black communities. And we really wanted to find an intervention that would not kind of end when the funding ended. And so we looked at technology-based interventions as potentially something that we could integrate into existing primary care workflows with existing resource constraints, and also that would be usable and acceptable within the end user population. Specifically, we proposed to design, with the input from our human-centered design and engineering colleagues, a community-informed conversational interface, or chatbot. Chatbots are technologies that mimic human-to-human interaction. So popular chatbots include Amazon Alexa or Apple Siri. And chatbots have been shown in research to improve trust of web-based information, and they're also easy to use and scale. We applied for and were awarded funding through the Patients Are First Innovation Pilot, which is an internal UW Medicine award that funds innovations aligned with health system priorities. And we started our work by getting feedback from the community. We conducted 21 semi-structured interviews with Black women living in Pierce and King counties. And these were all led by community engagement lead, Bridget Hempstead, who's pictured here. Bridget is the founder and CEO of Sierra Sisters, which supports BIPOC women in breast cancer diagnoses, and also does a huge amount of education and outreach to communities. And for the interviews, we asked questions about experiences with and barriers to breast cancer screening in primary care. And we elicited feedback from a chatbot mockup. And this is the initial mockup that we showed in the interviews. And this will show the process of scheduling a mammogram using the chatbot. And we elicited several themes from our qualitative analysis. First, participants cited several barriers to breast cancer screening, including barriers to resources such as cost, transportation, access to mammography. One woman shared, I was in West Seattle, a low-income area, and there needed to be more resources that help out women of color, and explain what mammograms consist of. Talk about the cost of it, talk about resources that individuals can tap into to be able to get a mammogram. Participants also emphasized the importance of outreach to get information about breast cancer screening to the community. Another woman shared, how do you know if you're carrying something around, you're sick, you're not knowing what it is, and when you get to the hospital, they diagnosed you. But there's things that you could have done prior if you was told. Some people don't know how to reach out. And finally, participants discussed lack of or equivocal recommendations by primary care physicians for breast cancer screening, even if they initiated the discussion. Another woman shared, and now I just need to bring it up again to my physician because I did talk to her about it 2 to 3 appointments ago, and she's not putting in the referral. Based on the interview feedback, we developed an early prototype of the mock-up tool. And so I'm going to bring you through a few screenshots for the same process of scheduling a mammogram with our newer refined prototype. And you'll see a couple changes. So we tried to make the icon more relatable and bring up a little bit more background information based on those interview feedback. And so we also conducted, following this, we conducted 3 focus groups of about 10 women total to elicit their feedback on these screenshots. And we're currently coding and analyzing that data right now. And so as next steps, we're going to iterate on and design an interactive chatbot prototype. And then eventually be able to build this out as real technology and pilot it. Finally, we hope to conduct a randomized pragmatic trial to really understand the effect of the chatbot in improving screening rates and reducing disparities. Our current funding is through the Optics Center, which funds pilots that use implementation science methods toward cancer control. And additionally, we're doing a quantitative analysis of racial and ethnic disparities within UW medicine using health system data. This will be used to inform our chatbot, but also will be used to feed back to the health system to understand better some of the factors driving disparities in different racial and ethnic groups that will hopefully then inform and improve health system interventions. So in conclusion, breast cancer screening disparities are really complex. They're multifactorial and they're rooted in systemic racism. And so it may not be surprising when typical population health management strategies do not work effectively to address disparities. And instead, we can use learning health system models, including interdisciplinary and community-based participation and partnership, and the application of research methods to really improve outreach efforts. And a huge thank you to everyone who has participated and helped to lead this research, including Dr. Vicky Fong, who I saw in the participant list today, and everyone who has supported my early career research, and again to the awards committee as well. Thank you.
Thank you, Dr. Marcotte. Once again, if you have questions, please put them in the chat, and Tess King will be monitoring the chat, but I'll start off with a question. Leah, you focused, the work that you described focused mainly on patients, and why patients may have difficult access to get breast cancer screening, et cetera. The other factor were also the providers, right? And so I think that's something that could be fixed within our system in some way, shape, or form, and it should be fixed. So how much is the provider the problem?
That is a great question. I think we're doing a analysis. It's called a Blinder Oaxaca decomposition analysis to look at the factors driving the disparities, and some of that will be able to potentially look at provider and clinic factors, as well as factors such as language and geography. And so we're hoping to be able to quantify that a little bit. I'm hoping also in my future work to really focus on the provider end as well, because I think that's a hugely important piece. We decided to focus this particular project in patient facing, but absolutely.
Leah, thanks so much for your talk. I have a question about the chat bot that you were talking about. Has that been used in other disparities, research about disparities in other areas of cancer screening or just cancer care in general?
So our colleagues in the Department of Human-Centered Design and Engineering have developed a chatbot for social determinants screening in ER specifically. And I have to go back. I don't believe that chatbots specifically have been, that I've found used in to address disparities at this point.
Okay, well, thank you, Dr. Marcotte, and congratulations on your Chair of Medicine Scholar Award.
Thank you very much.
Interesting presentation. So for our third recipient is Dr. Anna Weil, and Dr. Weil is in the Division of Allergy and Infectious Diseases. And I'll turn it over then to Dr. Weil.
Thank you so much, Dr. Lyles. Can everyone see my screen? Yes, and hear me? Okay. So I'm Anna Weil. I'm in the Division of Allergy and Infectious Diseases, and I'm going to be telling you today about a little bit about my path and about my work on the gut microbiota and Vibrio cholera infection and immunity to infection. And first, just want to shout out a thank you to the committee and to everyone here for giving me the opportunity to talk about my work. So I'm originally from Alaska, and I grew up primarily in Washington State in a small town called Edgewood, which is southeast of here, but on the west side of the mountains. I went to UC Berkeley for undergrad, and after that spent a couple of years working in public health in Ethiopia and Malawi, and then returned to the US to do my master's in public health at Johns Hopkins. I then went on to medical school at Tufts University, and while I was there, I took a year off to study T-cell immunology in cholera at this hospital pictured here. This is the International Center for Diarrheal Disease Research in Bangladesh. And I wanted to show this picture because this place had such a big impact on my career trajectory, and it's also where I met the collaborators that I still work with today. And all of the samples I talk about in this study come from cohorts that originate at this hospital. And then went on to residency, fellowship, and started my lab at Mass General, and then very happily was able to return here to the Washington area in Seattle in the AID division. So my clinical interests and my work in the hospital is focused on solid organ transplant infectious disease patients, which is very separate from people who are affected by cholera. I mentioned my research interests already, the role of the gut microbiota and enteric infections and immunity. And I'll just start out now talking a little bit about an introduction to that topic, and then go into two research questions that we work on in my lab. So on the top right here, we have a picture from the WHO a few years outdated of countries that have endemic cholera. Over the last several decades, outbreaks of cholera, as well as countries that have endemic cases of cholera, have been increasing due to political unrest, global travel, such as in what occurred in Haiti, and also due to warming oceans, which has increased the habitat of Vibrio cholera, generally speaking. So Vibrio cholera affects millions of people and is really a disease of the poor. If everyone in the world had the same modern sanitation infrastructure that we have in the US, cholera would go away tomorrow. There is a vaccine, a couple of vaccines that do protect against cholera, but the protection is limited, and the vaccines don't work well in children. And for reasons that are not well understood, the vaccines don't produce a protective immune response in some people. So that brings me to the two research questions. The first I'll talk about is the impact of the gut microbiota on susceptibility to Vibrio cholera infection. And the goal of this work is to develop probiotics or probiotic strains or products that contain bacterial metabolites that can be used for prophylaxis in a high-risk cholera situation, such as in a refugee camp, or for treatment to lessen the severity of disease. I first started studying susceptibility to infection and host factors that lend themselves to susceptibility in cohorts of household contacts of cholera patients in Bangladesh. When I was there as a medical student studying immunology, I worked as a side project on looking into the clinical outcomes of these household contacts, the other people in the household once there was a case of cholera. So we looked into these household contacts at this day 0 when they're enrolled, which is the day a household case presented to the hospital, and talked to them about their symptoms during the previous week, and then followed them prospectively to see how many of them developed cholera, and found that they were at very high risk for disease. So in this context, we looked into the clinical risk factors for infection. And as a infectious disease fellow, I wanted to transition sort of this angle of this work to look into how the gut microbiome itself might be a risk factor for infection. So I examined stools from this time point of time of enrollment, and looked at the gut microbiota of the people who went on to develop infection and compared this to those who did not develop infection. So in this first study, I'm showing you here an area under the curve plot of the clinical risk factors we know that predispose people to cholera, such as younger age and lack of pre-existing immunity, and compare this to the microbiota curve. And so what these curves indicate are how well a machine learning model, in this case, a support vector machine learning model, how well the model can predict the clinical outcome of the patient based on their microbiota alone, their clinical factors alone, or both combined. So what we learned from this was that the gut microbiota does predict susceptibility to infection. And the next step in this work, which we proceeded with more sequencing, was to identify what bacterial groups are responsible for this effect in this relationship. So briefly, I'll say the additional studies yielded lists of ranked organisms and strains of bacteria that were most closely differentially abundant and related to either being protected from infection during that follow-up period or developing infection. So the work in my lab currently in this arm of research is focused on these specific strains, or strains that have gene families or metabolic pathways that were linked to protection, and understanding more about the mechanism of how are these gut microbes either affecting the pathogen and protecting from infection, or otherwise impacting the gut mucosa that leads to protection from infection. So now I'll take you on a small story with one of these microbes. So I'm going to talk about Paracoccus immunovorans. This is a soil microbe that is not very well described. We found that when we cultured this bacteria, which in humans we saw was highly abundant in people who developed cholera, we found that there was a difference in biofilm formation when Vibrio cholera was exposed to Paracoccus. So you can see this sort of thin line up top is the biofilm layer, which is kind of a proteinaceous area that forms at the air-liquid interface. And this characteristic of cholera allows it to stick to oyster shells and also stick to the gut when it causes infection. So this is an important virulence factor for causing infection. So when we culture Vibrio cholera in this biofilm, we find that in the presence of the Paracoccus co-culture, there's much more Vibrio cholera here, and that in this pellicle, this is called the top of the biofilm, there's about a 1-to-1 ratio of Vibrio cholera and Paracoccus. So when we look instead at the planktonic area, so this is the free-floating part of the culture, there's no difference in Vibrio cholera in either place. So we concluded that this is some kind of effect occurring within the biofilm. So the next step in this work was colonizing a mouse model with Paracoccus and then challenging them with Vibrio cholera. And what we found was that there's much more colonization in mice that have been colonized with Paracoccus ahead of time. And when we use a Vibrio cholera knockout strain, which does not make as much biofilm, this is the Vibrio polysaccharide mutant strain, that this effect is negated. So from this, we concluded that this Paracoccus species that we saw in humans more commonly who had cholera does interact with Vibrio cholera in some way in the biofilm and induces Vibrio cholera to create more, we thought, VPSL. So we confirm this using imaging, and I'll just go through this very briefly. On the left side is all of the color staining layers together. So you can see that how they interact, but individually on the right, on the blue is Vibrio cholera. The red is the cell membrane stain showing mostly Paracoccus. The WGA stain is the Vibrio polysaccharide, and the overlay here is on the very far right. So what you can see is where there's more Paracoccus, there's also more VPSL, and we confirm this in other ways using expression data and other molecular methods. So that is the conclusion of my the first half of what I want to talk about regarding this work, and a shorter half I'll touch on the role of the gut microbiota in immune responses to oral cholera vaccines. Again, the ultimate goal of this work is to identify bacterial products that could be used as vaccine adjuvants, and especially to improve vaccine responses in children. So as I mentioned, not everyone responds to cholera vaccines. So we have used stool from people who respond to vaccination versus those who do not, who I'm calling here responders and non-responders, and examined their gut microbiota. In this situation, we used an unbiased probabilistic modeling method to group people by their microbiota, and we found that those in this first group were most likely to develop protective immune responses after vaccination. These are people that have more Clostridialis, less of Enterobacterialis, and actually a less diverse microbiota overall, which is unusual because usually we think it was a more diverse microbiome as being good, but in this case, those with more diverse microbiota were less likely to respond to vaccination. So to explore this further, we applied the stool of responders and non-responders, shown here as N and NR and R. We applied this to human-derived macrophage cell culture models that we used to model immune responses to vaccination, and measured innate immune cytokines in response to this stool. So we measure innate cytokines because we know that the innate immune response at the mucosal surface to vaccine antigen is what's critical for the development of the long-term memory B cell responses. And surprisingly, we found that there was a difference in IL-1 beta and IL-6 secretion in the responders and non-responders, but it was in different directions. So what this indicates, when we know that these cytokines usually are concordant in their expression, here what we see is that there's a difference, and that responders have a higher IL-1 beta. Their stool has that effect on macrophages in culture. So what this indicated to us is a specific part of the NF-kappa B activation pathway in innate immune responses that is more closely linked to responders. And this work was done by Denise Chak, a postdoctoral researcher in my group. So the next step in this work was, again, identifying specific strains that we can use to study the mechanisms of these responses. So to get a closer look at what strains we should be working with, I worked with Sam Minot at Fred Hutch here, who's a metagenomic methods scientist, and we used his method of co-abundant gene groupings to analyze the metagenomic data, and were able to identify specific strains that were most closely associated with memory B cell responses to vaccination. Those strains are shown here as dots, and you can see that there may be a difference between the strain effect, and this is ranked here by a priority score, which is essentially a composite score of how well the memory B cell responses were after vaccination, but that these strains come from some specific species here. And these species are not random, but these are species that generate microbially derived lipids, which is what I'd like to talk about in this last slide of data. So the bold strains here are strains we've actually been able to isolate from the study population. Chelsea Dunmeyer in my lab has worked hard in isolating these microbes so that we can work with them for this purpose. So what we did to follow on to this work was to conduct unbiased lipidomics of the stool from vaccine responders and non-responders, because we saw the signal that many of these microbes were lipid producers. So we found that in those more likely to have a vaccine response, there were specific ceramides, and this is a a principal coordinates plot where each vector is one specific lipid that was dominant kind of in the direction you can see of the arrow in these two different response groups. So ceramides can be in the diet or made by the human host, but there are specific ones that are made by only bacteria. And we found that this difference was pretty stark between vaccine responders and non-responders. So that work is ongoing, and I'll just say for future directions regarding the susceptibility work, we have ongoing screening of bacterial isolates to see how they impact Vibrio cholera virulence, to define mechanisms of action, kind of always originating back with our human data and what those signals tell us as we move forward. And then in the immune response work, we are moving forward to determine the contents of the microbe supernate fractions that impact innate immune responses in our models of Vibrio cholera immune response. And with that, I just want to thank quickly in my lab, Denise Chack, Chelsea Dunmeyer, Fred Heller, and Gwen Dumayas, our undergraduate, my collaborators at the ICDDRB, led by Dr. Firdausi Qadri, many others here that I mentioned during the talk, and here at UW, Jason Smith, Anna Wald, and Wes Van Boris, who have been instrumental. And I'll put up my QR code for evaluating my talk. And lastly, just want to mention my husband, Neil, who's also in the Department of Medicine, and our two kids, Juna and Avi, are shown here. And I'd love to take any questions, and please email me if we don't have time for all of them.
Yeah, thank you. Thank you, Dr. Weil. That's quite interesting. One of the things I was struck by, is that differential response in IL-1 beta between responders and non-responders, right? And I think it calls to mind, IL-1 beta is a product of the inflammasome, caspase-1 activity. And there's a parallel in influenza work, where, in other words, you need caspase-1 activity and inflammasome activity to respond to an infection with protective immunity. And so I think that might be the key, and not necessarily pro-inflammatory cytokine production, but more inflammasome activity.
I agree. Surprisingly, when we have in my group conducted in the past RNA-seq and proteomics on biopsies from the small intestine during cholera, we actually see a very interesting immune response that's quite similar to a viral infection, to our surprise, specifically focused on NLRP3 inflammasome. So that is actually the focus of much of this, is to understand, why we know that's happening in acute infection, and how do we replicate that more closely in vaccination. And it does seem like there's something about the microbiota of those vaccine responders in which there's a polarization of the mucosa that results in vaccine antigen promoting more of that NLRP3 inflammasome activation. So yes, I've learned more about viral immune responses than I thought I would working in this bacterial infection.
And just a follow-up question. You mentioned, that the current and past cholera vaccines have not been very effective. How much immunity do people acquire, protective immunity, from natural infection?
Yes, great question. So there are studies from the 1970s and 80s in Bangladesh, field studies that are, I would say, pretty definitive in saying 5 to 10 years, but it's not lifelong immunity like we think of, in some other infections. The vaccines, though, really for a 2-dose regimen, which is quite unrealistic in a lot of these settings, or at least harder to achieve, really are more in the 2-year range for adults, and really quite poor protection for children. And even then, 20 to 30% of people don't seem to be protected after a couple of months. So we have work to do in improving those vaccine candidates.
Dr. Weil, I just want to ask you a question from our chat as well. A question about if you have been looking into if there are any influence from if there is any influence from the diet.
Great question. I think that it's likely that there could be. We have not studied this in Bangladesh, which is our main site for a place where there's endemic cholera. Diet in many developing country settings tends to be very uniform across people. So we've been worried that we won't be able to detect a lot of differences. But it's definitely, there's so many environmental factors that may also be playing a role that we definitely would benefit from accounting for those.
Okay, well, thank you. And I want to congratulate all three recipients, Dr. McKenna Eastment, Dr. Leah Marcotte, and Dr. Anna Weil for being named as Chair of Medicine Scholars for 2021. Once again, this award comes with more than just a handshake. It also comes with $100,000 over 2 years for either salary support or research support. But congratulations. Thank you for your presentations.
Thank you so much.
Thank you.
All right, so that concludes our grand rounds for this Friday. And next week, our grand rounds is going to be the John Butler Endowed Lecture by Jeremy Kahn from University of Pittsburgh. The title is Defining and Improving Teamwork in the ICU. See you next week.